afternoon. Again, welcome everyone to the Summit Healthcare Host webcast featuring Ephraim McDowell Health and their connection to the Kentucky State Health Information Exchange. I have joining us today Becky Blevins, who is the Information Services Project Manager there at Ephraim. She has a ton of background and has worked on a variety of IT-related projects related to interfacing, as well as was a huge part of their connection with the Kentucky HIE. I know Becky also supports the hospital there from a variety of different standpoints, and very knowledgeable, and we've been happy to have her as a client for many years and work closely with Becky and the team there at Ephraim. As mentioned, Becky's going to go through her story here today, bringing that to the audience, and if you can stay on, we're going to keep it open for a Q&A. I also have joining us Matt Johnson, who is our product manager, and will be demonstrating the integration technology just to kind of show how an interoperability platform from a technology standpoint can assist with these types of efforts. And that will be a very short demo, probably only 5 to 7 minutes, but certainly want to get this excellent story brought to you today. So with that, I'm going to go ahead and turn it over to Becky. Becky, I can see your screen. It looks great, and I'll just let you take it away.
Thanks, Tara. This is Becky Blevins, and I am the IT Project Manager here at Ephraim McDowell Health. And what we'd like to share with you today is just our experience on connecting to our State Health Information Exchange. And so, as always, I'm obligated to give you a little history about Ephraim McDowell. We are a healthcare facility that has comprised of 2 hospitals. We have an acute care hospital and a critical access hospital, and they're about 7 miles apart. We also have a surgery center that's for outpatients only. Recently, we have been certified as HIM Stage 6. We have also attested for our initial 90-day evaluation period for Meaningful Use Stage 1. In September 2011, we received a Pioneer Award from the Governor's Office for our work on connecting to the Health Exchange. And we've also been recognized as one of the top 25 most connected facilities by Health Imaging and IT in 2011. We have a variety of outpatient offerings as well as our inpatient facilities. We have a wellness center, a children's place, which is basically our daycare, MedSource, an extended care facility, and multiple diagnostic facilities. We also have many family medical centers, and these family medical centers are in the 7 to 8 counties that surround the central location of our main facility here in Danville. So let's talk about our EHR journey. Ephraim McDowell implemented the base modules of Meditech Client Server in 2002, and we've continued to add on to that with some of the more advanced clinicals, including nursing documentation, bedside medication verification, CPOE, and e-prescribing. And then in 2010, we implemented the LSS clinical applications for our outpatient family medical centers. We have integrated our peripheral clinical systems such as cardiology packs, radiology packs, vital sign monitoring, and fetal monitoring. And then we're also sending outbound laboratory radiology dictated results and a variety of other physician office EHR products such as Centricity, Varian, Allscripts, Meridian, Sage, EMD. And then recently, well, last year now, it seems time flies, we began sending information to the Kentucky Health Exchange as well. So there will be a lot of thought that you have to give to your HIE product, and some of these decisions, if you can begin talking about them now, that will make your whole project go a lot easier. And there will be signed participation agreements that you'll have to complete with your HIE. But one of the key items is what type of data can your HIE accept. Most HIEs will accept all admit, discharge, and transfer information, as well as lab, path, micro, and diagnostic results and dictated reports. However, some HIEs are not quite ready yet to receive immunizations and syndromic information. Fortunately, here in Kentucky, we are able to already send our immunization information, and the syndromic surveillance will be probably the end of the summer, and we can begin sending that information. So when you're making your connections, some of the choices that you'll have to decide on is, will you purchase all these feeds outright from Meditech? Will you purchase the CCD interface from Meditech, which is sold as a suite at a very expensive cost? Or do you have an interface engine that will help you redirect some of your existing Meditech feeds that will allow you to control your timelines as well as save your organization quite a bit of money? So you also need to think about who are the team members that you'll need on your HIE project. You'll need an IT resource, and of course, being the project manager, I put the project manager first. You'll also need some IT resources to work on just the basics of your interfaces as well as data mapping. Regardless of what state you're connecting with your HIE, they're probably going to have some sort of data mapping between what their race tables or language tables are, ethnicity tables, as opposed to what your HIS system is producing. It's key when you're working on an HIE to have a physician champion or a system admin who is really the champion of that and is out there speaking to the rest of your organization and helping them to understand what's the value of actually connecting to an HIE. So many times at an organization, they have access to so many systems that it sometimes is not obvious to them that if you have all the information from multiple facilities throughout your area or your state, all presenting data in one generalized location, what a benefit that can be, as opposed to having to log individually into separate systems or contact separate facilities. And that physician champion will help you with that. You'll also need a team to do your data validations, and you'll need specialists from admissions, lab, diagnostics, and from your health information management, or what we used to call the medical record department. Because while your IT resource will understand, that the data is flowing or how to manipulate certain pieces of data, it's really these key people on the validation team that will make sure that the data is represented in your HIE the same way that it's represented in your HIS or some peripheral system that you're sending from. Some of the considerations as far as your ADT is you'll need to talk with your HIE and see if they can accept all message types. Sometimes there are a few message types that cause problems for your HIE, and some of those are the different, whether you're merging at a patient level or an account level. Sometimes your HIEs have problems handling those. And then also on the flip side of that, talk to your HIE about how they handle an unmerge, because we've all ran into that issue where we have a patient that gets merged from the medical record department, and then, maybe a week later we find out that that merge should not have happened, and so we need to unmerge that patient record. And we need to make sure that as we merge and unmerge that data is displayed correctly in your health information exchange. A17s are usually a specific problem for HIEs because those are bed swaps and not really merges or unmerges of accounts or medical record numbers. And so some HIEs have a problem even accepting A17s. And sometimes when they accept it, the HIE software doesn't know exactly what to do with it. You also need to talk with your HIE about if they can handle pre-admitted patients. If you have a pre-admitted patient and they've never been with you before, then through Meditech there's an account number that's assigned, but not a medical record number. And so, if you send that message out to your HIE, one of the key indicators for most HIEs are medical record number, and without that, then it may create an error on the HIE side. and you may have to filter those pre-admit patients out from your initial ADT using your interface engine. Some of the other things that we ran into is, if you have users who have open text comment fields and they enter backslashes, instead of using a forward slash, a backslash to the HL7 world means stop here, and that's not all what the person intended to happen. They were just trying to divide up a particular field in their comment. And so some of those things will cause issues for your HIE as well. When you're sending your lab data, you need to talk with your HIE and make sure that the reference ranges from your submitting facility are actually displayed there along with the results. You have different pieces of lab equipment that result things differently, and you need to make sure that whatever your analyzer, whatever reference ranges that analyzer used, that those show next to your result. Also, the comments that are on any particular test, you need to make sure those show as well. Sometimes those comments are just as important as the result itself. If the actual specimen was not of good quality, or maybe it was coagulated and they weren't able to process it in their normal way. Talk with your HIE about how a corrected lab result will display. Will it actually append to the end of the original result, or will one overlay the other so that the end user only sees one result? Talk about how culture and sensitivities will display as well. Make sure that how it's displaying in the health exchange really represents the same way that your end users would see it on your HIS system. Make sure that those things that it's, sensitive to, or maybe it's not as sensitive to, that those are obviously displayed so that there's not a misconception about whether it was sensitive to that particular drug or not. And the other thing is most HIEs will not allow you to send HIV and other confidential test results. And so you need to have a way to filter those out, whether it's, if you buy your interfaces from Meditech, then you'll have to have some type of custom in order to be able to filter those HIVs out, where if you have an interface engine in place, you can simply go in and ask it to filter on any type test that would contain, the characters HIV or whatever designation you have for those confidential tests. For your diagnostic and dictated results, again, you'll need to talk with your HIE about how an amended and a corrected report will display. Some HIEs actually attach the amended report to the bottom of the original report, and there's a clear designation that it's an amended report. Others will actually have the original report there and then followed by the amended report. And some of your users may click on the initial report and not actually go and take the second step to see the amended report, and so they may not have the most accurate information. You also need to discuss whether you will show draft reports as well as finals. There are good and bad in doing each. If you show the draft reports, then obviously that information on a particular patient is available on the health exchange much faster than if you only show finals. But if you do show the draft reports, then there's obviously the chance that there is something that is not correct in the draft report. Maybe the provider left out the word no, and that has a huge impact on the final report when he actually goes back and reads it. And the original report said the patient has no sign of calcification, and when he actually reads it, the patient did have calcification. So whether your report types will be individually identified is key as well. Providers really are at a fast pace today, and they don't have time to go through tons of reports and click on them individually to find out that this is an operative report, and this is a discharge summary. So you need to make sure that your HIE can identify the report type so that the information is displayed in the most effective way for your providers. Talk to your HIE about what's the process of removing a report. There are probably not any of us that work at a facility where we're not asked to do some type of unsigning a report, and maybe a report gets put on the wrong patient, maybe that report gets put on the wrong account, and so in the old world we would just go back and collect the pieces of paper, but in the electronic world then we need to know what's the process. Is there a formal written process like we have to have here in Kentucky whenever a report needs to be removed from the health exchange, or is it a designated person that you can call? Most states have specific data stewards that do nothing except monitor the data, monitor the quality, and go in and resolve issues, whether it be errors with duplicate medical record numbers or removing reports. And then also, if there's more than one radiology result that's associated with one of your reports, sometimes that creates an issue for health information exchanges. Because there will be multiple accession numbers coming from your PACS system, then the HIE sometimes, when you try
Muted.
two results. I think Tara has unmuted me again now. With two results on the same radiology report, sometimes HIEs, once the HL7 message goes through and it processes the first accession number related with the first study, sometimes HIEs have a tendency to stop reading at that point, and it won't actually display your second report that's associated with that same study. Who uses HIE data? At our facility, we began our initial pilot with our ED physicians and nurses. We also included our health information management or medical record staff. Since then, we have rolled it out to our infection control specialists, and they look at a variety of things, but specifically they're looking for lab results from other facilities that would show whether a person had MRSA or C. diff. That helps us to be able to place those patients into isolation much quicker. Then you've got your tumor registrar, and they do follow-up and treatment. You've got pharmacists who are doing medication reconciliation and immunizations. Case management uses it for patient history and long-term care use. And then you've got your specialty clinic staff. We have an indigent patient facility, which is called our Hope Clinic. And we treat patients that are at 150% of the poverty level at no charge. And those patients are usually normally or poor historians, and so having access to the HIE data gives us some idea as those patients travel throughout the state of some of their medical history. Some of the additional functionality that you need to talk with your HIE about is, do they have disease-specific lab results displayed? As you include your LOINC codes on your lab results, then most HIEs are now able to display that so that you have all of your diabetic-related tests lumped together, and that helps your providers to also buy into the use of your HIE. Can your HIE route results automatically to other providers? Fortunately, here in Kentucky, our HIE contains this additional functionality, and it has been great for us because we no longer have to go out and install individual desktop faxing or fax servers in order to get results to pass from one person to another. You will also want to make sure that the HIE allows you to be able to modify and change your date ranges relative to your patient data. As your HIE ages and you have many years of data in there, your physicians are not going to be patient enough to scroll through pages and pages of data. You need to be able to modify and change the relevant dates so that they only see probably the most current 3 to 4 months worth of data. Does your HIE contain symbols denoting abnormal or critical values? And do those abnormal and critical values also correspond with what your HIS system produces? Is there web-based access to your HIE for CCD retrieval? And one of the keys for us is that our single sign-on product also work with the HIE, because the easier it is for your physicians to use the HIE, obviously the more likely they are to use it. This is just a depiction of how our data flows here in Kentucky. And then some of the specifics that I'd like to talk about are just, how we've used the interface engine here at Ephraim. We've had a long-term relationship with Summit, and some of the things that we've had to do is obviously we have had to filter on our HIV patients. Some of the lab results that we've had come over from our Meditech system, if the lab result is canceled, then Meditech places a D status in the HL7 feed. The Kentucky Health Exchange actually needs an X to be a canceled status. And so on the interface engine, we can go in and simply replace that value with another one. There are some of the separators that Meditech uses in their standard HL7 feed that the Health Exchange is not able to process. Sometimes we have to replace an asterisk with a caret, or, we're able to quickly make all those changes on our interface engine. As you begin to initially send data, even as you have your validation team working, you're still going to have a limited number of messages that you're sending. And so after you go live with your Health Exchange, you're going to identify that there are additional errors that will have to be resolved in order for all of your data to flow cleanly to your state health exchange. And just expect that no matter how much testing you do, there's always going to be something unusual. Maybe a new test gets created. There could be a variety of things. And just know that, with Summit's engine, it has the flexibility when your health exchange calls and says, I'm receiving errors on this type of data. I need something different in this field, or I need the information from, 3 fields over brought in and placed in this position. Summit's engine has the flexibility to allow you to do that quickly and then be able to, have all of your data flowing cleanly into the health exchange. So with that, I'll turn it back over to Tara, and we'll look at some quick shots of the engine at work.
Hey, thanks. Becky, can you hear me okay?
Yeah, I can hear you now.
Okay, I think Tara might be on mute. So I'll just take over presentership. This is Matt Johnson. I am the product manager for Express Connect. And let me share my screen here. So I'll just do a brief walkthrough of the layout of the engine where you would build and maintain your interfaces. So let me log in here. We support Active Directory, so you can log in with network credentials. That controls that you have proper access to your interfaces, and also all your changes are tracked. So if you have multiple people working on interfaces and there's ever an issue, you can see who changed what and the old and new values and roll those back. So here's the engine itself. We have the ribbon menu up top to walk you through your specific functions and utilities you need to use. In the center, we have our list of interfaces that are grouped by inbound and outbound. So you always have more outbounds than inbounds because you're taking something like an ADT and duplicating it off to destination systems. In the bottom panel, you have your individual interface settings. So as I select different interfaces above, this panel updates, and I have different tabs for controlling their settings. Also in the grid here, I have some key values or settings for the interfaces, such as the interface type and vendor, obviously the name, whether there's a map, that's our Summit Apex mapper, whether there's a map associated to it, and your connection details, what ports you're listening on, what folders you're monitoring, where you're sending messages out to, etc. For your outbounds, you also see the queue that you're pulling messages off of. So each vendor has their own queue that they work off of. So the flow is that interface messages come into the inbound interface. This would be an outbound from Meditech, an inbound to the engine, and get delivered to your different queues. And then you have your outbound interfaces picking them off of those queues and sending them out. And I have just a brief animation slide to show that, just to kind of be a little bit more visual for those who prefer. So here you can see example of message coming in, goes out to a couple pass-throughs where there's no conversions being done. So it lands on the queue, gets sent right out. And we have one, we're going to check the message before we send it out. And then on this other one, we're going to do custom mappings and changes before we send it out to the HIE. So whether it's just another vendor system or an EMR or an HIE, it's all able to be handled throughout the engine via our mapper and standard interface flows. So specific to some of Becky's examples, I have some scenarios in here where I have connections to Rio. This was examples directly taken from our integration with the Colorado Rio. And you can see here some changes that are being made when we're sending lab results. It has some filters here. So this SAM tab is basically showing you the documentation of what the map does for this interface. So it automatically documents everything you build. So this wasn't handwritten. The engine actually produced all of these documents. So it says only send final and complete results, that is entered by the user, but the condition is if OBR25 equals final or it equals complete. So it's making sure that only completed results are sent. It's also only sending from this certain facility based off of some data in the MSH. Also modifies the OBR segment. It looks like it's reordering some fields, which sometimes they need to receive those in a certain way. Here's our ADT that's going out to that Rio. So you can see I select that other interface, and now this panel updates to show me the details of this map. And again, there's some changes going on. If it's an A38, we're changing it to an A11. One of those examples where the HIE can't handle that type of event, so we change it to something else that they can handle. Modify the insurance segment to make sure that certain values are filled in, etc. So if you do need to change something, so maybe they say that there's something in the PID segment that the name is in the wrong place or the gender is incorrect, we can just open this mapper and see the message. And let's say that I do need to do something to the PID. I'll just make a new segment. Let's say update the PID segment. And let's see, so maybe this field needs to go somewhere. So let's say that the business number is supposed to be in the next field instead of in this field. So I can say, let's see, mapping, and I'll just say assign to variable, which gives me this command builder. And instead of putting it in a variable, I'll just say actually put it in PID 15. So very simple. My input is PID 14. My output is PID 15. And I click OK and test that and take a look at my output. Just resize this a little bit for your benefit. Now I can see that PID 15 has that number in it. Maybe they also needed that home number to be moved to PID 14 from PID 13. So they wanted, let's say, being shifted down. I can actually highlight PID 13 on the left, PID 14 on the right, and say mapping, map PID 13 to 14. So it recognizes this relationship between my input and output message. So now that command gets generated for me, and I can test this and verify that that data has been moved. So I added a new section which does these two commands. I haven't touched any of my other mapping, so everything else is going to work exactly the same. And as I added these, it updated the documentation with my new logic, which says assign PID 14 to 15 and 13 to 14. So very simple and self-documenting. So I'll save that map and I will close it. And now when I come back in here, I can refresh, see that that documentation has updated here, restart that interface, and now this will take effect for all future messages that come through and go out to this HIE. So the engine can do any of those types of integrations as well as standard, vendor to vendor connections, state health initiatives, where maybe you're not necessarily sharing as much data and potentially you're actually removing patient identifying data. This was an example of a New York have-bed program where they just want things like the month and year of the date of birth and the zip code. They don't want the actual account number, the name, none of that. It's mainly kind of a statistical tracking project. So that's something else that you can also do with the mapper and Express Connect engine. So in in a full demonstration, we'd be happy to get into more details and build specific mappings to anyone that's interested, and also review our message logging and our dashboard for alerting and monitoring. But for today's presentation, I just wanted to give a quick look and feel of the product and of the mapper and its ease of use. So hopefully this was useful to you all, and I'll hand it back to Tara.
Hi, everyone. Yeah, thank you so much, Matt and Becky. I was on mute, and I figured out how to fix that. So actually, I'm going to just re-show, Becky, your screen, if that's okay, just so we can put up that final slide. Thank you, Matt. Becky, if we could just see that final slide with contact information. And there we go. Thank you so much. So folks, if you have any questions at this time, we'd be happy to open it up for any dialogue. As I mentioned earlier on, as people were joining, we will get a copy of the presentation out to you all, and I did do a taping of the presentation, so we can re-listen to that and review it at a later time if you want to pass it along internally to any colleagues. Does anyone have any questions for either Becky or Matt from the technology standpoint? Okay, looks like we have a question from Sherry. Let me go ahead and read that off. And Becky, I'll address it to you first, and perhaps Matt as well. The state of Missouri will require a CCD instead of ORU results messages. Can we use our EC engine? I'll actually direct that over to Matt. This is from Sherry at Citizen.
Sure. Thanks, Tara. Yeah, we're currently in the beta process of our CCD support. So we're actively testing that with a few clients that have CCD set up. So it is a very different format than HL7. It's not pipe delimited, it's XML. So we are making changes to support that. It's also a query response communication model, which is very different than the unsolicited HL7 communication model. So there are some differences there. But you can send it through the engine, or you will be able to when we release that version. You just want to make sure that you have your specs between Meditech and your HIE squared away so that they're comfortable with the format and the the communication techniques.
Okay, thanks, Matt. And I don't know if you know the answer to this as well, but whether or not they'll need to purchase the Meditech CCD interface suite, if that's something you might need to discuss offline, or if that's come up in the past.
Most likely you would need to purchase the CCD suite to produce those summary reports. maybe at a later date we may add other functionality within the engine to help you kind of simulate those, but I can't really say whether that's going to meet the requirements of any specific destination system. So definitely something to think about, but that's kind of down the road.
Okay, great, thanks. And Sherry, of course, you can certainly reach out to your account manager to further those conversations here at Summit Healthcare between Citizens and Summit in regards to furthering the connectivity with the engine. Does anyone else have any questions around connecting, or how Becky and their organization went about the process? And if you think of things at a later time, certainly feel free to reach out to either myself, I can pass it along, or to Becky directly. Well, thank you, Becky. We appreciate you joining us this afternoon and taking the time out of your schedule to present. Thank you, Matt, for the demonstration. And as I mentioned, we'll go ahead and do a follow-up email out with the presentation and a link to the webcast so you can view it again. And with that, I'll go ahead and close the session. We are a little bit before 12:45, so please go enjoy the rest of your day and have a lovely weekend. Thanks, everyone. Take care. Bye-bye.
Thank you. Bye-bye.